So the current state of ischemic stroke therapy is particularly for the most severe kind of stroke, which is a large vessel occlusion that has a really dramatic impact on the well-being of patients. About 4 years ago now, we had 7 randomized controlled trials conducted that showed mechanical thrombectomy, so in the hands of specialists going up into the brain with microcatheters and removing the clot, restoring blood flow to the brain, is not only an incredibly powerful treatment that half of the patients will recover from and be functionally independent after 90 days, in other words, taking care of themselves. But it has a treatment effect that's actually profound in medicine, not just in neurointerventional surgery. So the number needed to treat to have a positive outcome is between, depending on the trial, 3 to 4 or 5. If you compare that to other areas of medicine like percutaneous coronary intervention, which has been the standard of care since the 80s, this is a very powerful treatment effect. Those numbers needed to treat are much higher. So this has been really, in medicine, an incredible development, and the state of therapies right now for acute ischemic stroke as compared to where we were before these trials is incredibly good. Intraarterial access to the middle cerebral artery and to the areas where patients have occlusions causing stroke. That's been possible for a long time, actually, and in fact, there was a positive trial done in the late 90s using catheter-directed thrombolysis. It was called the PROACT trial. The development of technology took some time, but the first generation, which is well, not the first generation, but the post-retriever generation, so the stent retriever generation, which is what's led to these incredibly powerful trials, that started in the late 2009, 10, 11. And these devices were actually incredibly effective at removing clots from the brain. The next generation that we're evaluating in my laboratory, so we have the good fortune to work with a lot of different technologies, and the next generation is going to be even more powerful. So now I think it's time to turn our attention as a community more to the brain, and what can we do before the thrombectomy procedure to give the brain the best chance of a good functional outcome. I think the future for ischemic stroke is very bright, especially for that worst kind of stroke, which is a large vessel occlusion. I think we're going to see therapies given in the field, rapid diagnosis, therapies given in the field that allows the brain to better survive that injury until you can get reperfusion to the brain. And then we're going to continue to see advancements in peri-procedural, post-procedural brain treatments that help the neurons, help function, and then recovery as well, and neuroplasticity. There's been amazing progress in these areas. I know it's slow for the patients, but with a glimpse of the future, it's very positive. Technique is really important, so the tools that are being developed by the industry, by academics, are very powerful. But the thing is that it still requires an operator to use them. And we've been very fortunate in this area that we've had really expert people driving these therapies, but now as the demand for the procedure grows, that's going to be a very important opportunity to make sure that techniques in practice are kept up to standards with the technology. There have been enormous advancements in technology to get the clot out of the brain arteries very efficiently, which is a definitive treatment that helps patients. And now I'd like to move attention in the space to coupling, having a more complex solution that focuses on brain and survival of the neurons following this ischemic event, so that we have a more comprehensive, higher quality, good functional outcome, which is now about half of the patients to 60% of the patients. We'd like to see that be more like 90% of the patients.